We have a lot of ground to cover this morning in 50 minutes. We'll do our best to get to as much of it as possible. It's really the economic impact of chronic disease that we're going to be discussing, but prevention, early detection, and better management are going to be what we focus on. Mike Milken and others have talked a great deal about the work we've done on the human and economic consequences of chronic disease. Almost a decade ago, we did a study called Unhealthy America, which kind of documented the human and economic consequences of chronic disease in terms of treatment costs, lost productivity, lost economic growth opportunities. And we just released a study this morning, in fact, looking at dementia and how it affects women in the economy overall. And the short message is the burden on women is enormous, especially as caregivers to those afflicted with dementia. So improving health is a core mission of the Milken Institute, both in terms of finding cures, but equally importantly, if not more importantly, prevention and better disease management. And we're going to touch on medical costs in this session and some of the economic consequences as well. But we really want to spend more time talking about prevention. We'll probably talk about modifying unhealthy behaviors, a little bit on obesity and some of the latest statistics on the causal connections between obesity and various disease categories. So we'll talk about accountable care as well. Some experts on the stage who can share their expertise on that, and all of them share a passion for improving health and controlling costs at the same time. So why don't we get into the panel discussion? Enough of that intro. First, I'd like to welcome Nancy Brown, the CEO of the American Heart Association. She's pulling double duty today, having served on the opening panel. So we're very pleased to have her on our session as well. To my right, your left, Neal Kaufman. He's the Chief Medical Officer at Canary Health and Adjunct Professor of Medicine and Public Health at the University of California, Los Angeles. Those of us in LA know it as UCLA. Also from California, Kristen Miranda, who's Senior Vice President of Strategic Partnerships and Innovation at Blue Shield of California. Thank you for making the journey to the East Coast. Next to Kristen, we have Hugh, who's a health economist and associate professor at the University of North Carolina School of Nursing and Public Health. And last but certainly not least, Otis Webb Brawley, who's the Chief Medical and Science Officer at the the American Cancer Society. Nancy, if I could, I'd like to start with you. You've set some very laudable goals for your organization in terms of reducing cardiovascular disease for Americans by about 20% and reducing death associated with that. Could you share with the audience some of the human and economic consequences of cardiovascular disease and maybe highlight what it does to the economy, making the case for better prevention?
Sure, I'd be honored to do that. Just by a bit of framing, the American Heart Association in 2010 did set a decade-long goal to both reduce deaths from cardiovascular diseases and stroke by 20%, while improving the cardiovascular health of Americans by 20% during that same time frame. And just a bit of framing about the urgency of that goal. As we sit here today, fewer than about 3% of all Americans are in ideal cardiovascular health as we would define it, and that really gets to the core of the problem. In the world today, 17.5 million people die of cardiovascular diseases on an annual basis, about 800,000 here in the United States. And we recently published an economic impact survey that showed that the costs of cardiovascular diseases are expected to top the direct and indirect costs about $1.1 trillion by the year 2030. And so these are important areas of focus, especially since we know that 80% of cardiovascular diseases are preventable. And that is why we are so focused at the American Heart Association on helping all Americans know and understand their risk for heart disease and stroke and other vascular diseases and trying to help them take action to reduce it.
Thank you, Nancy. We'll get back to that in just a minute. You've performed extensive research on kind of the causal links between unhealthy behaviors from smoking, diet, lack of exercise, and many health conditions. Could you maybe give us a sense of the importance of various lifestyle choices in terms of relative risk for different chronic diseases? What difference does it make if we're unhealthy?
Sure.
Thanks.
Thank you, Russ. So I've done a lot of research using a combination of epidemiologic tools and economic tools to tease out the costs of diseases and look at the risk factors associated with those diseases and what the contribution economically is of the risk factors. So the first step in that process is to look at a relative risk. So for people that engage in a risky behavior, what is their enhanced risk of contracting a certain disease? So the relative risk is simply the probability that those who are exposed to a risk factor or a behavior will contract the disease divided by the probability for those that will not. So essentially, if relative risk of 1.3 means that those who are exposed have a 30% higher chance of getting the condition or the disease than those who are not. So this is a powerful tool with the relative risk, and if we also know the percentage of people that are engaging in that behavior, we can calculate something called a population attributable risk, which is what percentage of the diseases are associated with that risk factor. So it's a powerful tool to say, of all the conditions of chronic obstructive pulmonary disease out there, how many of them can be considered to be associated with smoking or exposure to secondhand smoke? And so then the economists come behind and put numbers on that, but that's a different part of the picture. But just in terms of the epidemiology and the risk, there's very powerful evidence now linking smoking, exposure to secondhand smoke, obesity, even drinking, alcohol abuse, all of those to various chronic diseases. And without taking too much time, I'll just go through some of the key ones. Smoking, of course, it's been well established for quite a long time that smoking enhances your risk for various diseases. Smokers smoking 25 or more cigarettes a day are 10 times more likely than those who don't smoke to get lung cancer. No surprise. Other big ones, they're 3 times more likely than those who don't smoke to get bladder cancer, 10 times more likely to get COPD. So that epidemiological history is well established, and I don't want to go too far into that, but it can be useful then in terms of teasing out, how many cases of those conditions are actually attributable to smoking, and then we can say how much does that cost. The debate over smoking is pretty much well established, and the outcomes are well established in terms of the epidemiology. We've recently gone through a debate over secondhand smoke and whether governments should be involved in restricting smoking in public places. That argument is kind of winding itself up too, and pretty clear that there is a risk of exposure to secondhand smoke. The relative risk there, people that are exposed to secondhand smoke are 1.3 times more likely to get coronary heart disease, CHD, than those who are not exposed to secondhand smoke. People exposed to secondhand smoke 1.2 times more likely to get lung cancer. Those are the two big ones. And so I've done quite a bit of research taking those kinds of numbers. There's also diseases that kids are more likely to get being exposed to secondhand smoke. But for adults, CHD and lung cancer are the big ones. Taking those and teasing out, how many cases of those two diseases can be attributable to exposure to secondhand smoke? I've done this in several states that were considering passing legislation to restrict smoking in public places. And it adds a very powerful argument to be able to say to a state legislature, of all the cases of COPD or coronary heart disease or lung cancer in your state, and a good portion of those paid by Medicaid, paid by state health insurance, paid by Medicare as well, and this is an argument going to both the federal and state governments, that the government pays a significant portion of the tab for those bills. And so that really brings a sound argument to the point that, government does have a rationale to intervene, restrict smoking in public places, because government, one way or another, is paying a fairly big part of the price tag for those conditions caused by exposure to secondhand smoke.
Thanks, Hugh. Perhaps we can come back to a couple of those other ones. Otis, I want to get you into the discussion. You've long been an advocate that this nation, if it were serious about reducing racial, ethnic, gender-based health disparities, that it must widen access to care. How does expanding coverage and access help to address the poor health and rising costs in the healthcare system? Maybe another way to put it is, how do we slow the growth in healthcare expenditures by bringing a larger share of the population into the system?
Well, first, let me say, if we can prevent these diseases and prevent suffering, it's actually in the long run going to be cheaper. And when we talk about disparities, I started my career talking about black-white disparities. Now I frequently talk about state-state disparities. For example, we've had a 40% decline in breast cancer death rates in the United States over the last 25 years. I'm a cancer doc, so I'm going to use a cancer example. Not in 12 states. 12 states have had only a 10% or less decline. So what I'm saying is prevention, diagnosis, and treatment is not homogeneous across the entire United States. There are tremendous differences. So I'm now starting to talk about Louisiana, Pennsylvania disparities instead of black-white disparities. In answer to your question again, if we can prevent these diseases, if we can practice evidence-based medicine, I would point out that there's a lot of cancer screening, again, a cancer example. There's a lot of cancer screening going on in this country that is not evidence-based and is a pure waste of money, a complete waste of healthcare dollar. And indeed, probably a third to 40% of our current healthcare dollar would not be spent if we simply practice what the evidence showed. And when I say a third to 40%, that's expanding it to the people who need help and taking away from the people who overuse health. And keep in mind, too much health care can be harmful. Many people don't understand that.
Thank you very much, Otis. Kristen, allow me to turn to you. You're in charge of Blue Shield's, California's efforts in innovation in healthcare. Innovation in healthcare, not always together, right? Necessarily in the same sentence. But I guess my question that I wanted to direct you first is California now kind of playing a leading role in changing the healthcare delivery model from more of a sick care system to a more true value-based healthcare system? Or where do we stand in terms of moving away from the typical pay-for-service model? What are you doing in California?
So I think we are certainly all over the country moving away from the traditional fee-for-service model, right? We see it in pockets all over. The challenge, I think, is we're not moving quickly enough. And so I do think California, in some ways, has been on this path for a long time, right? We've been working on population health for decades and decades. I don't think that the results in California necessarily bear that out all over. In fact, that was music to my ears to hear the absolute underscoring of practice variation, not just from state to state, but from community to community, and sometimes even from one physician to another. So what we've been doing with organizations that we think really share our values, and that means a commitment to getting quality up, costs down, really focusing on outcomes. We've created a model where it's not magic, but where we are really tied together to look at a population from each stakeholder's view, sharing all kinds of data. We just heard in the last session a fascinating conversation about big data and the role that that's going to continue to play as we go forward. But I think we need to do sort of two things. We need to absolutely focus on creating the right kind of integrated, multidisciplinary clinical models that folks with chronic disease need to have. But we also need to make sure that we're looking at data to give us predictive modeling and other sorts of views into those populations that may be teetering on, transitioning into a chronic state. And what do we need to do to prevent that?
Thank you very much, Kristen. We'll come back to that in a minute. A good segue to you, Neal, since you focus on doing exactly what she said should be done, Canary Health. Kind of the movement from a patient-centered model of healthcare service delivery. Your approach is quite different from the more traditional one that tends to focus on a specific disease and how you manage that patient through the disease, what I might call a more holistic approach. Maybe you could share your philosophy, and in other words, what's your business model?
If you look at adults in America or anywhere in the world, as we get to be 50, 60, 70 years old, we accumulate more and more chronic conditions, on average every 3 years. So taking a person who might be overweight, sedentary, maybe has a little high cholesterol, high blood pressure, then they get prediabetes, and then they get low back pain, and then they get sleep apnea, and then they get arthritis, and they continue to get that. Now, I could have given you that story, or I could have said they started out with depression and then got diabetes. You could pick your conditions, 8 or 10 of the most common ones. And the average individual adds a new one every 3 years. That's the natural history. And by the way, they're still not very sick. Maybe 1 out of 10 of them have a catastrophic event like a heart attack, a stroke, kidney failure that puts them into the very, very high cost. That's only 1 out of 10. But 9 out of 10 just sort of go along. And the question becomes, how do you approach them in such a way that you give them the health they need for the life they want? That's a fundamentally different approach that has to do with performance span and not lifespan alone. With all due respect to my profession, which is medicine and public health, at the medicine side, we've been trained to extend people's lives. We have not been trained to extend their performance. I want to die completely healthy. I want to be healthy today, and then not today. I want to be healthy sometime in the future. Thank you.
You can be healthy today, too.
Okay, as long as it's not on your time. I want to be healthy and then die the next day. I think we all want that. The question becomes, how do you change those trajectories? We're all on trajectories. We start out as little kids, hopefully getting better and better, and unfortunately we go like this. Is modifying that trajectory a little bit by helping someone lose weight, eat better, be more active, not smoke, manage their stress, overcome lack of connections to other people. You can make a profound difference in their lives. When you do it from that perspective, you save money very quickly, actually. Imagine that you slow the rate of adding new chronic conditions within a couple of years, which is the longest horizon I've been able to find a health plan or even a healthcare provider organization to think about from a financial basis. You can save money fairly quickly.
Thank you very much, Neal. Otis, you've discussed the number of cancer cases that might be prevented through inadequate access to care, or at least quality care. Could you maybe explain the magnitude of the preventable cases in terms of cancer and how you determine them?
Yeah. Well, first off, a lot of disease, by the way, is due to, we think of it as a three-legged stool of obesity, high caloric intake, and lack of physical activity. And that is the second leading cause of cancer right now, will be the first leading cause of cancer within the next 20 years. It causes a lot of coronary artery disease, causes diabetes. What our epidemiologists did was we looked at people who have pretty good life expectancy, and that is college-educated Americans. And we looked at what would the death rate from cancer be if all Americans had the death rate of college-educated Americans. And it turns out there are going to be 596,000 cancer deaths this year. If everybody had the risk of death of college-educated Americans, there would be 148,000 less. A third of all the cancer deaths are preventable with current technologies. If people have the lifestyles and the availability of cancer diagnostics and treatment, screening, and prevention that college-educated Americans enjoy today. 148,000 lives. No new technology, no new science, except how to get what we currently know to everybody in America.
Yeah, very good. Thank you, Otis. Nancy, how about other diseases, cardiovascular disease? Any sense of how much of it is preventable in terms of changing lifestyle choices?
Sure. Yes, 80% of cardiovascular diseases are preventable. And, you know, I have to just to add on to something Otis said earlier, we also look state by state, but you can see these differences zip code by zip code. And, you know, I always love to quote Risa Lavisa-Morey, the CEO of the Robert Wood Johnson Foundation. She talks about how you can get off on a train in Princeton, New Jersey, and have one set of life expectancy and go the next train stop and have a different type of life expectancy. So I think that while we know these risk factors for cardiovascular diseases are largely preventable, getting the solutions, you know, helping our communities become healthier so that everyone has access to these interventions that work is a really important thing that has to happen. You know, high blood pressure is a really interesting thing to look at, and you can see the same types of disparities in terms of people based upon college education, based upon age, of course, about blood pressures not being under control. And we know that high blood pressure leads to heart attacks and strokes and leads to other important causes of death and disability.
Neal, what about type 2 diabetes? How much of it could potentially be prevented?
Well, if you look at the natural history of type 2 diabetes, the vast majority of those individuals have been overweight and then obese for decades. even in young children. We're not seeing type 2 diabetes in young children. We're seeing it in teenagers and young adults, where it used to only be an adult disease because of the childhood obesity epidemic. And if you look at the evidence that says that if you help someone eat better, be more active, just those two things, obviously stopping smoking would help too, but eat better, be more active, you're able to lower the rate of going from prediabetes to diabetes by 58%. 70, 80 million Americans have what's called prediabetes, which means that they're on their way to getting diabetes. Natural history will be they will get it over minimum 10 years or maximum 10 years, whichever way you want to think about it, and that by changing their lifestyle, they can make a profound impact on the rate of getting diabetes.
Thank you very much. Let's turn now to looking at the Affordable Care Act. It's still early in the process, but what evidence do we have thus far? And I might ask you to share with us what we can say at this point, and then I'll turn to you, Chris.
In terms of cost savings and models of care?
Correct.
Sure. Well, the ACA is, as I'm sure all of you know, is a very complex piece of legislation, over 1,000 pages, I think it was. So I've done work to sort of distill the different pieces of it and look at the impacts of different aspects. And there's a lot, too many certainly to go through here, but there's two that we could bring up in the context of this conversation. One is to promote the use of accountable care organizations, which I'm sure most of you are familiar with. This is initially a Medicare model, the ACO model, in which groups of providers work together and work with each other to provide the best care they can for a patient, and including referral to hospitals from primary care providers. So ACOs work under a couple different models. For Medicare, there's a shared savings program under which the provider can actually benefit financially if their costs come in lower than projections, under Medicare projections. So, and there's also a Pioneer program in which the incentives are even higher. So participants in the Pioneer program stand to potentially gain or potentially lose more funds than under the shared savings program. So these two have been highly popular. There's ACOs that have popped up really all over the country, and we've seen that there's been some really good results to date. So we have a total of, let's see here, we have 350 or more than 350 ACOs now in the United States that are registered with CMS. Okay, and under the shared savings program, Medicare is expected over the course of the decade, 2010 to 2019, expected to save about $5 billion, while at the same time improving the health outcomes of the patients that are served by these ACOs. And then, as I said, the Pioneer ACO, which is relatively new, has even stronger incentives. The Pioneer program, though, is no longer open for enrollment. So Medicare has closed the door on that one for the time being. And then just this year, 2015, CMS announced the next generation modeled ACO, looking at specifically issues of coordinating care for populations in population health level. So the ACO experience has been, and there's people on the stage that have direct experience in implementing the model, but the evidence so far has been encouraging as a way of providing networks of providers with financial incentives to keep their patients relatively healthy.
Thank you very much. Otis, you had a point you wanted to make.
Yeah, we've actually got some data to show that the expansion of health insurance for children to the age of 26 or 27 has actually created some improvements in treatment for cervical disease already amongst women in their 20s. There's some improvements from the Affordable Care Act. Also, one of the great advantages, and unfortunately I'm a cancer doc, so I'm going to give you cancer examples, in states that have expanded Medicaid such that people now have access to health care, if one is having bowel problems, one can now go to a doctor, and frequently you see someone diagnosed with a colon cancer that is stage 1 or 2. That same individual in states that have not expanded Medicaid without access to preventive screening usually ends up in an emergency room after they have collapsed because of blood loss or because they have bowel obstruction, and those people are diagnosed at stage 3 or 4. By the way, I can cure a stage 1 or 2 colon cancer very cheaply a stage 3 or 4 is, one, not going to be cured, and two, going to live 2 to 2.5, maybe 3 years, consuming very expensive chemotherapies. Getting back to that first thing about saving money.
Right. Kristen, let me turn to you. Your organization has been a leader in moving to the accountable care model. At this stage, what are some of the findings from the program? I mean, I know you've implemented it. It's a limited longitudinal data set, if you will. Excuse me for being an economist for a moment. But if you could give some examples of programs that have been engaged and what some of those outcomes have been thus far, at least.
Sure, yeah. So actually, we have been, we started this in 2010. So we're actually now in our 7th year of the very first accountable care collaboration that we embarked on. And in the spirit of full transparency, we're calling it an ACO now. We started this work before the passage of the ACA. So we were frankly calling it a big, bold experiment, and let's see how it goes, right? And it's actually gone incredibly well, and certainly we're continuing to learn and refine, monthly it seems like. But we started with one. We've got 32 now across the state. What we have found is that, and this is not, I don't think, a surprise to probably anyone up here or anybody in this room, it's not rocket science, right? We kind of know what best practices are. We know what it takes to manage not only a chronic population, but also to do preventative care for those that are healthy. What's been missing, I think, largely has been, first of all, an economic model that incentivizes all the key stakeholders to, in fact, embark on that. And that's part of what we designed with a large physician organization and a large hospital system when we began our work. So I think part of it is, frankly, just we've got all of these disparate, fragmented, siloed stakeholders across the country, each of which in some ways is kind of operating in a silo, maximizing their own kind of individual piece, right? That's not going to work. And I think that that's really what the accountable care sort of program that CMS has outlined is really attempting to get at. Our model is a little bit different from CMS's model, either the Pioneer or the shared savings. I think, though, that given that they are sort of the country's largest payer, I think what they're doing is incredibly, could be incredibly transformative. What we have seen in our own results is that we have saved, on average, across our entire program, and keep in mind some really have been in place for almost 7 years now, we've saved on average about $40 to $45 per member per month. And keep in mind, we are working with some organizations who are really quite sophisticated and have done some very good work for years. But what you find when you bring these fragmented pieces together, even with integrated delivery systems, we are finding that there is plenty of opportunity for improvement. So it's been exciting to see, and as I said, I think we're really at the beginning of this. I think the question for us and the question for the country is, are we going to move quickly enough?
Right. Neal, you raised this on the conference call we had in preparing for the panel, and maybe I can get Kristen on this too. Begs the question, is the point that you made that many insurers are looking for a return on their investment within 2 years. So I guess the question is, what is the ROI that maybe you're looking for and you're trying to help them achieve?
Well, so I will tell you, that is a very real problem. It just is, right? We're in a very, I would say, kind of enviable position in some ways. We are a not-for-profit, and with us, that actually means something. We take it very seriously. We really are able, in many ways, because we're not beholden to stakeholders every quarter, we, in fact, have been able to really look long-term, and we see it as our mission in California to improve the health and to reduce the cost of the entire population. So we are making significant investments in that. A lot of our provider partners don't really have the resources to kind of augment some of their clinical programs that we know would really drive value. But it is a very real problem because it's something that we've got to tackle as an entire industry. And it's true that some stakeholders, many of them health plans, but also provider organizations, are not convinced they're going to have that member 3 to 4 years down the road, maybe not even 2 years down the road, right? And what does that mean? Well, it means you're not going to reap the ROI for the investment you've made up front. Somebody else is. The problem with that mentality clearly is it's been a driver to getting us where we are today. And so we're taking, I think, in some ways a bold sort of drawing a line in the sand in California and saying it's the right thing to do, we've got to do it. And if somebody else ends up benefiting from either the programs that we've implemented, from the investments that we've made in keeping patients healthy, then that's kind of the price of admission. Over time, it will all begin to, we think, come back.
In response, Neal?
Yeah, so I think you might have one. Well, this is a public health meeting, so I have to obviously talk about public health as one of the major approaches that health plans and healthcare providers should support. We know that public health is earlier on in the section, in the progression, that you can use policy, you can use environmental context to make a difference. If you then also say, in concert with that, you really, I think, need to look at how do you help individuals manage their lives with their chronic conditions. If you look at any of the chronic care models, Wagner's et al. And others, self-management support for an activated patient with a responsive health system, with a community that supports them, is what seems to make a real difference. And so whether you do that from a direct-to-consumer approach, whether you do that from a personal health services approach within the context of a one-on-one physician-patient or clinician-patient relationship, or a population health approach, if you put the patient at the center and you help them to be able to manage their lives with that chronic condition. By the way we do that is using digital technology to lower the cost. Because if you can take evidence-based programs that we know work in person, that the cost, logistics, and price and other barriers make it hard for that to go to scale. You can go from 100 to 500, but you can't go from 500 to 5,000 to 50,000 to 500,000 if you have to have people in person. Using digital technologies that we and others have created, you're able to go to scale with large numbers of people with evidence-based programs that help them self-manage their conditions in their lives. How do you get that ROI really depends on where you're looking. If you're the employer, you're getting employees who think you're a better employer, they're more loyal to you, they come to work more ready to work, they've lowered their depression, they've improved their health, they've saved you money in the long run and maybe in the short run. If you're an at-risk provider or an at-risk plan, if you're able to lower that rate of adding new chronic conditions, lower the rate of people falling off the cliff, and that's really tough. If you're on your way down, it's very difficult to do that, but maybe the year before. So with big data, you can predict which of the 10% of the people in this room, I'm sure none of the people in this room are that way, I hope, are going to fall off the cliff next year. And then you can perhaps do more intensive services for them. You can then take those people who are just going to add another chronic condition within the next 3 years and lower that progression. And you can save significant money for some 20 to 40% of the population that fits in that risk.
Thank you, Neal. Otis, you made a profound statement on the conference call that we had, one-on-one especially, and I wanted to bring it up. You made a statement along the lines of fixing third-grade education may be among the most impactful things that we could do to improve health. So what did you mean by that?
Well, when we look at who does well in the healthcare system, who does not do well, and who has relatively low mortality, who has high mortality, the educated always win out. And I think I said fixed third grade because I think that's about the point in the United States where people either start being vectored toward not being a high school educated person or toward being high school educated, toward being literate in society, including literate in how we use healthcare, and not being literate, toward having healthful habits or having non-healthful habits. I would point out that those states that don't do very well that I talked about are the states that have the lowest educated people in the United States as well. I would point out that when we talk about smoking, there are very few college-educated smokers in the United States today. Most people who smoke are actually not even high school graduates. So when I say fix third grade, I mean fix the whole educational system. But I really do think that we start losing people at about third grade, and things by fourth, fifth, and sixth grade, everything is predictable.
Neal, I'm going to quickly back to you. And then
so there's an urban legend that planners of jail cells look at the third grade reading level of a community and predict who's going to go to jail. It's not been proven to be true, but symbolically it really is true. If you look at preconception, intrauterine exposure, first 5 years of life, if you're able to help those individual children who are at risk for falling off the trajectories get back on the trajectory, third grade reading level, which is summate of all of those prior to third grade experiences, predicts poor health, predicts jail, predicts alcoholism, predicts a range of things. And so I completely agree with you, starting further back, obviously, because third grade is a little too late to start.
Well, actually, I think we've covered it. But the bottom line is that a patient's or a person's health status is largely impacted clearly by the community and the socioeconomic conditions in which they've sort of grown up. One of the things that we're trying to do now in the work that we're doing is figuring out how do we actually start to work with and leverage some of those community resources, right? So how are we integrating some of this work, or at least involving schools and the community clinics and churches, et cetera? It's a huge challenge, right? Clearly, it's a huge challenge. But that's something that I think we've absolutely got to get to. And I do agree, by the way, digital technologies are going to be critical in the future in expanding access, for sure.
Nancy, if I could turn to you. You and your organization have done a lot of work with employers and how to motivate employees and family members to make better lifestyle choices. Some might call this the carrot or stick approach. So really, my question is, what works better? Is there something that works better, or is it a combination of two, depending upon the circumstances?
Sure. And maybe just a bit of framing on the work that we've done. One of the wonderful benefits of the Affordable Care Act is that the issue of health care became a CEO issue, not just an HR issue in our companies, and that's great. We have, at the American Heart Association, a very robust roundtable of CEOs that have agreed to serve as an incubator for new testing, new solutions, looking at digital health technologies, looking at this, the ongoing question of incentives versus disincentives, rewards versus penalties. And, I think we all know the evidence base is very thin. And we intend at the American Heart Association, through our new Center for Workplace Health Evaluation, to try to build scientific resources to help support the directions that things need to go. On the issue of employee engagement, though, let me just say, as we launched our new workplace health business, we did a big nationwide survey with Nielsen that looked at what do employees want. All this discussion is what do employers want, what do physicians want, what do health plans want. Well, what do employees want? That's really, these are the people that need to make these decisions to change their life. They want to work in organizations that support their whole being. That they want to admire the leaders of their companies and see that they are focused on health. And those that see their senior executives focused on health, those that are inclined to have positive impacts towards health themselves, will adopt healthier behaviors, and not just adopt them, but sustain them. And that really, of course, is the question of all of these programs that have been done in the workplace. How do you not just have someone help adopt a behavior, but how do you sustain them? This is why, as part of our new effort to recognize and reward companies nationwide for achieving better health outcomes for their employees, we've partnered with IBM Watson and with WellTalk to serve up a suite of digital tools and predictive analytics for companies so that they will be able to look at their whole population as a whole and help target programs that will truly make a difference for their employees.
Thank you, Nancy. Anyone else want to weigh in on this topic? Let's turn to an even bigger topic. You've doing a lot of work on obesity, and I mean it's no great revelation that obesity has been linked to many chronic conditions, but the latest epidemiological evidence tends to suggest it's much more pervasive than we ever thought even 5 years ago. If you could maybe just give the audience an update on what does it show the other diseases, how much are related to them. I know it's a wide area to cover in a short period, but let's do our best.
All right, I promise not to read out too many numbers. As an economist, I love numbers. So I've had the opportunity to be involved a bit with the Institute in terms of researching some of the economic impacts of obesity in a similar way that I described earlier, looking at secondhand smoking, and I've also been working on alcohol and other types of risk factors. But obesity kind of the epidemiologic evidence is very, very, very strong. So in terms of the relative risks, like I was talking about earlier for other risk factors, the relative risk for people you can talk about people that are obese and also those that are overweight. But people that are obese, their relative risk of having end-stage renal disease is 3.57 compared to people who are of normal weight. For women, 3.2 for ovarian cancer. for everybody, 2.1 for Alzheimer's, for people that are obese compared to those who are not. The list goes on and on. Diabetes type 2 is probably the biggest single one in terms of the economic contribution. People that are obese are 3.4 times more likely to have diabetes, and those that overweight are 1.5 times more likely to have diabetes. So that's just a quick overview of the epidemiologic evidence. And then similarly to what I was talking about earlier, we're going to come behind that and add up the price tag of all those cases that could be attributable to overweight and obesity.
Thanks, Hugh. That's a good, quick summary. I appreciate it.
Try to.
I know, it's a tough one. I share your affliction for numbers, too. So let's move on. We talked about this a little bit, but I wanted to get back to it before we get to our wrap-up stage here. Looking at how do we move from a culture for pain from procedures to pain per prevention. And the Affordable Care Act moves us in that direction. But what else do we need to do to encourage physicians and other health providers to move to more of that base model? Kristen, I'm going to look at you first. What changes need to take place?
Well, it's a challenge because I think we know largely how to drive in that direction, right? It does come down to creating economic models that reward providers not for doing more, but for doing the right things, right? The challenge that I see is that providers, I think, all get it, right? I talk to them all day long. They understand that we are moving as a country into this direction, and frankly, we have to. We've got a very short period of time now to figure this out. The challenge that they have is in trying to manage in two worlds, right? It's sort of like having one foot on the dock and one in the boat, and you're teetering back and forth, right? And providers, many hospitals in particular, who I think have a huge challenge, probably more than almost any constituency in the country right now in making that transition, will tell you. Once all of our business moved into this kind of model, great. Until then, I'm going to have to consciously or not manage populations differently. So what I think we can do is to help create a glide path, right? There are ways, and probably too much for here, but there are absolutely ways that I think we need to design systems that help these providers move into the new world order while not destroying them in the process. And I think that's the challenge.
I think the way to do that for practicing physicians is to help them to recognize that the team approach to individuals with chronic illness is much more effective than the rugged individualist, physician, paternalistic, I tell people what to do sort of approach. And when you distribute the responsibilities across a range of people, you focus on them in quite different ways. And so we've had horrible experiences trying to get physicians to refer patients to our self-management programs. They're so busy. They have so many other things to do. They're worried about their insulin fixes and all these other things. But instead, if some part of the organization can generate a list of people who are targeted appropriately for this with approval by the patient, you then would market to them using modern marketing techniques the fact that there's a program that's offered. And what I've seen from that is, I remember one of our participants in our weight loss program said, I never thought my health insurance cared about me as much until they focused on my weight. Because that's something that she cared about. That's something he cares about. And that meant the employer, it could mean the provider are doing things that the patient wants. And when you frame it that way, patients will accept it, and the clinician can go on and make sure that the right dose of medicine is being used and other diagnostics.
Nancy?
Certainly agree with all those points. And I think your last point I just wanted to add on to, as we all sit around and think about the system and the doctor and the insurer, we've got to focus on the patient or the consumer and what will inspire them to care about their health. We dream that we can find a way to inspire patients to push the doctor and push the system. That's going to affect change as much as, I believe, new financial models, because one would hope that most practicing physicians in this country want a partnership with their patients. They, of course, want their patients to be healthy, and patients cannot be passive. And so we've got to do more to inspire patients to take control of their health. And I believe many of these new technologies that will give patients actual real-time data about their health can help make that happen. And if we can remember that always, it is about what is a patient's aspirations, not what's wrong with them, and how do we help patients achieve their aspirations in life.
Anyone else? Otis, please.
I'd like to get a little bit more public healthy.
to use that phrase.
You can do that.
Let's keep in mind how we got to obesity. You know, in the 1950s, every family wanted to have a car. Now most people have 3 cars. We drive everywhere. We don't walk. We moved to the suburbs that don't have sidewalks. We bought big refrigerators. So instead of walking to the grocery store every 2 or 3 days to buy fresh foods and cooking them, we drive to the grocery store on Saturday, load up on all of these calorie-dense, preserved, frozen foods, and bring them home. We've got to start looking at the built environment. We've got to start putting exercise back into our everyday lives. We've got to start talking about what it is we're eating. You know, these are all public health issues that we've truly got to address. One of the great problems in the United States is 4% of our kids aged 6 to 12 were obese in 1970, and it's over 20% by 2010. Okay? I have a lot of data to show that getting heavy makes you unhealthy. The data to show that getting skinny returns you to health is not nearly as good, folks. We got to start talking about prevention, not just in the doctor's office, but in all aspects of our life.
Very important point, Otis. We're going to wrap up, and I want to give everybody a last chance to give the audience your key takeaway. What do you want them to take away from what we discussed in this panel? Nancy?
Don't forget about the patient and the consumer. They're the driver.
Neal?
Use cost-effective digital approaches combined with in-person approaches to help patients be at the center of their lives to improve their health.
Agree with those, and I would just add that there's a lot of incredible work going on all over the country. So as challenging as it is right now, I really am incredibly hopeful that we're going to make some meaningful progress.
You?
I'll keep it quite narrow. Use available data to influence policy. There's tons of available data about both the epidemiology, the economics that we can use to really drive policy.
Otis?
5 to 9 servings of fruits and vegetables every day.
There we go. That's a specific one. Very good.
Physical activity for at least 45 to 60 minutes, 5 times a day, and don't smoke.
Wow, 5 times a day?
Oh, I'm sorry, 5 times a week.
I was going to say, wait a minute. Very good. We'll get moving. With that, why don't you join me in thanking our panelists for a very interesting discussion. Thank you very much. Thank you, Kristen. Thank you. Thank you, Neal. Appreciate it. Thank you.